Welcome, everyone. Let food be thy medicine and medicine be thy food is a phrase often ascribed to Hippocrates and is almost certainly a historical misquotation. There's no single definition of the food as medicine concept, but it generally refers to prioritizing diet in an individual's health plan. Food as medicine has been, or nutrition, let's say, has been central in many traditional forms of medicine, but its role started to decline in the last century. The approach of food as medicine challenges our conventional modern Western model, which relies primarily on technological medical advancements and pharmaceutical drugs. As researchers, Kate and myself are deep into the contentious literature on this topic, and we're excited to share it with you today. So shifting focus or paradigms and questioning stylized facts often comes from interdisciplinary collaborations because we need to shake things up and question the stylized facts that we've become attached to. So in this case, we have a behavioral economist, that's me, and a medical biochemist, and we joined forces together with healthcare practitioners and a health coach to try and design the optimal program to put diabetes into remission.
There is a growing burden of chronic disease worldwide, and from a purely economic perspective, there's a huge amount of merit in reversing the trend in diabetes. Diabetes has increased globally to 9.3% of the total world population. And in South Africa, in 2019, we were sitting at about 4.6 million people diagnosed with diabetes. Here in South Africa, mortality rates of non-communicable diseases are set to overtake those of infectious disease by 2035. In 2019, the Indigo Wellness Index labeled South Africa the unhealthiest country on earth, which is quite shocking. And in 2017, diabetes was the number one underlying cause of death in women. Most shockingly, currently, the latest stats put 67% of all South Africans as pre-diabetic. The risk of death is 50% higher for diabetics. Medical costs are 4 times as much, and the public sector costs for both diagnosed and undiagnosed diabetes are exorbitant. One doesn't die from diabetes, you die from the complications of diabetes, such as heart disease, kidney failure. You also have blindness and lower extremity amputations. All of these are pretty severe complications. So this package contributes to a huge burden on families, patients themselves, hospital systems, insurers, and the economy. So, diet is a major contribution to the problem. We eat highly processed inflammatory foods such as industrial seed oils, refined grains, and sugar. Our day-to-day habits like sitting around for hours and hours on end, not exercising enough, stressing too much, not getting enough sleep, are not how our bodies were designed to be used. All of these things combined, our daily habits, are what drives insulin resistance and in turn causes metabolic syndrome and diabetes. Most of the food that we eat is turned into glucose or sugar for our bodies to use as energy. And the hormone insulin tells our body that we need to take up fuel when it's around. We need to take up fuel when it's around and available. When you have diabetes, your body either doesn't make enough insulin to meet the fuel or sugar demand, or your body doesn't actually respond to insulin correctly. This causes sugar to build up in your bloodstream and leads to hyperglycemia or sugary blood. Most of the food that we eat is turned into glucose for our bodies to use for energy. And the hormone insulin tells our bodies to take up the fuel when it's available. When you have diabetes, your body either doesn't make enough insulin to meet the sugar demand that you just consumed, or eventually your body stops listening to insulin and doesn't respond as it should to the signals that insulin is giving your cells. The end result of this is that sugar builds up in your blood and causes sugary blood or hyperglycemia. And eventually, this leads to insulin resistance if hyperglycemia sort of perpetuates. Carbohydrates are the major stimulator of insulin secretion, and chronic excessive consumption of carbohydrates and or calories can promote insulin resistance. This drives fatty acids into your blood and build up in your adipose tissue and your liver. It also means that you have an increase in inflammation, atherosclerosis, and you gain weight. The hedonic properties of food make us eat more than we need, and the high glycemic index carbohydrates trigger an addiction-like neurochemical and behavioral responses to us. So if you eat too much carbohydrates or you have a chronic positive energy balance, you get insulin resistance. So total carbohydrate intake is directly proportional to insulin resistance. So carbohydrates are the major stimulator of insulin secretion. And they also promote hedonic eating or food addiction. The hedonic properties of food make us eat more than we need, and the high glycemic carbohydrate triggers an addiction-like neurochemical and behavioral response. Carbs also significantly increase our sympathetic nervous system activity. This is because they stimulate insulin the greatest out of the three macronutrients. This increase in sympathetic nervous system activity activates our fight or flight hormone, noradrenaline, which increases our blood pressure and constricts our muscle capillaries and constrains their uptake of glucose, leading again to a greater increase of glucose in our bloodstream. Noradrenaline further affects your liver. It slows down its fat cycling. So again, we've got more fuel floating around in our bloodstream and a greater push towards insulin resistance. So it's not all bad news. Diabetes remission is possible. And with standard treatment, it's actually quite rare at about 1% of all cases and usually occurs with greater frequency after bariatric surgery or severe calorie restricted diet. That's about 850 kilocalories per day or less. It's really not much food. And in terms of diet, given the effects that carbohydrates have on insulin resistance, severe carbohydrate restriction has the potential to put type 2 diabetes into remission. And over the last decade, there has been an explosion of studies on low carbohydrate diets to treat type 2 diabetes. A low carbohydrate, high fat diet consists of 20% protein, so that's moderately high amount of protein, 70% healthy fats, and only 10% of carbohydrates. So, how did they work and why do they work? Well, firstly, low carb, high healthy fat diets achieve a greater amount of satiety. So you're eating less to achieve the same or adequate nutrient level. Also, they shift our metabolism to a fat-burning one. So this is a protein-conserving form of starvation because we're now using fatty acids and ketones instead of glucose for fuel, basically. Also, now that we've removed a lot of the carbs and the highly processed carbs out of our diet, we get a decrease in our sympathetic nervous system stimulation and a lowering of our blood pressure. And our muscles can actually function to take and respond correctly to insulin to take up all that glucose that's floating around, or in this case, ketones and fats. You also have an increase in insulin sensitivity, both in your liver and our fat cells. Low carb, high fat diets also generate ketones as the byproduct of the metabolism. Ketones alleviate inflammatory processes and they turn our mitochondria into super energy burning machines. Then we've also removed the carbohydrates, or most of them, and so we stop having that sort of addictive reward system that carbohydrates tend to lay down. And in the end, we end up eating real food. And for a diabetic, real food is medicine, and carbohydrates are potentially poisonous.
So even when we know what we should be eating, lifestyle change is a huge challenge for many of us. And with finger prick testing, you can miss the damaging postprandial glucose excursions, which become a silent killer. So digital health monitoring technologies may offer innovative solutions, But we have to pause to remember that more information doesn't necessarily translate into better health outcomes. So there's really a problem of frequency of feedback, and 15 minutes with your doctor at a yearly checkup is not nearly enough time to put into place lasting behavior change and healthy food habits. So as a limited intervention, perhaps after an elevated HbA1c test has been flagged, CGM, or continuous glucose monitoring, could be used to raise awareness along with nutrition education about the different impacts of our food choices on blood sugar. So why are CGM insights so useful? Well, the number of calories from a donut or from a Greek yogurt might be the same, but they can produce very different impacts on our glucose. And the CGM highlights this so well. Also, our other lifestyle choices, such as sleep or physical activity, as well as our stress, can affect how our glucose responds to high-carb foods. And the spike on one day could look very different to the spike on another day, depending on how much sleep we got. So in the UK, people with diabetes test on average twice a day using finger prick testing. But how often would they check if it didn't hurt? Well, if we remove the pain cost of monitoring, engagement is actually about 8 times higher. The increased engagement with blood sugar translates into significant improvement in the markers of diabetes that we use, so HbA1c and time in target range. And this is at least according to Abbott's consumer data. So remember that this is a self-selected sample and might not be representative of type 2 diabetes of patients not using insulin yet. Because CGM is really prescribed for type 1s and type 2 who are injecting insulin. So with these caveats, what the real-world data shows us is that we can get pretty far in achieving glucose control with just providing access to real-time feedback. But for many of us, information gets our thinking brain briefly lit up, but unless we feel like it, no action follows. So our feeling brain is really the one that's in charge. So what's the missing ingredient for behavior change? So do we perhaps need a new medical model to reverse the alarming prediabetes trend? Conventional Western medicine evolved in a time when acute infectious diseases were the leading cause of death, but now things aren't quite so simple, with lifestyle being the main driver of our burden of disease. So addressing the root cause means lifestyle change, not instructing people on how to take chronic medication. So this is where health coaching potentially comes in, and a model of wellness in which the patient is an active, engaged collaborator. So our acute infectious chronic disease model is perhaps not a good tool to deal with the slow burn of lifestyle and destructive choices. So the model could look something like this. Picture health coaching at the intersection of health information and behavior change. Health coaches aren't advisors, sports coaches, mentors, counselors, or even diagnosticians. They're health behavior change specialists. And they support clients in discovering their own strategies and their motivations for change and enable them to overcome the obstacles that are in the way of the protocols or plans that they have and have come to in joint collaboration with either a GP or a nutritionist. So this question is really what motivates our research. How can we support type 2 diabetes patients to achieve remission and healthy food habits? And one of the privileges of primary research is that you have an overview of the big picture statistics. So that would be on the left-hand side. And then also on-the-ground stories of patients' personal successes and challenges, which you're seeing on the right. So we've got one of our participants who was so pleased and proud of his success, and it was really such a joy to share in this with him. And then on the left-hand side, we're zooming out to the big picture patterns, which is really a deep understanding of how these treatments are supporting people and the individual challenges that they have. So in the end, we all have the same goal, but there's a myriad of dietary and lifestyle approaches to get there, and many of them are controversial. So our food habits are culturally, historically, and environmentally shaped and highly personal and important to us. So it's an empirical question what works, and what works in one population may fail to help another if we don't consider the case-by-case basis barriers to achieving engagement with the eating plan. So in the clinical trial that we ran last year, we gave a group of South Africans a continuous glucose monitor, or CGM, and this technology helps to generate objective health data, which is quite difficult to obtain in the field without patients. We randomized patients to one of 3 different treatments on a rolling basis, and we stratified it on gender and HbA1c level at the start. So that might be mild, moderate, or high. So the control group was a CGM that can't be viewed until it's downloaded intermittently at the doctor's visits, and it's shared in a supervised way. And actually, all our patients wear this type of CGM during the baseline 2-week period. So that's phase 1, CGM A. Phase 2 is the main intervention period of 4 weeks, where all the patients get nutrition education and instructions to test their glucose before and after meals. And really the only difference between control and info is the type of CGM worn in phase 2, so the main nutrition intervention period. So we're switching from one that hides the information from the patient to one that gives them real-time access during the day. And then coaching is taken weekly for 4 weeks, and then once every 2 weeks for 2 months after that. And no patients wear the CGM during phase 3, which is our 2-month sustainability period. This is really to let the effect of the CGM wash out and see if the healthy habits can be sustained. And our groups were similar at baseline, which is really important in terms of the evaluation, because it means that any differences in HbA1c or health markers after the intervention can be attributed to their treatment group.
Our medicine in this trial was food, a very low carbohydrate diet. And as mentioned, this has been shown to be an effective treatment for diabetes. The doctors in our clinical study provided an hour-long nutritional education session on a low carbohydrate diet, and they used sugar scales as references so that our participants knew exactly how much sugar was in their bowl of oats in the morning or the slice of toast that they had for lunch. Our doctors advised, as is part of their standard practice at Medicross Kenilworth, they advised that our participants eat less than 10% carbs per day. And that equates to about 25 grams of carbohydrates. And for reference, 1 Snickers bar is 55 grams of carbohydrates. So no sweets, no chocolates, and very little bread and pasta. We also provided our participants with the Nutrition Network's endorsed green, orange, and red food lists. Our participants were told that they could eat as much as they wanted whenever they wanted from the green list. They had to limit the amount of foods they ate off of the orange list, and they had to avoid completely, never touch anything on the red list. We also provided our participants with helpful banting recipes and links to low carbohydrate groups where people shared recipes. And they were also told that they could contact the research team whenever they felt that they needed to.
Our control group is also going to receive some kind of CGM feedback. So this is what the doctor discusses with the patient, no matter whether they're getting real-time feedback or wearing a Libra Pro, which hides the the feedback until it gets downloaded. So you can see they also get access to time and target range, average glucose, and daily patterns, so they can see when they're spiking around which meals. So this is a very controlled glucose graph, obviously. Actually, it's mine. And I hope that makes you curious about what I was eating at the time. You can ask in the comments. So one finding that is really key to come out of our study is that 46% of patients across all groups achieved remission. So we're defining this as an HbA1c of less than 6.5% at 3 months. Now we're looking at the CGM measure of average glucose. We saw that a significant decrease was achieved by all the groups while wearing the CGM. Now in phase 1, CGM-A, you can see the baseline usual habits, and these tend to be above our upper threshold of 8 millimole, which is actually more ambitious than the general consensus, which goes up to 10. So in phase 2, CGM B and C, you can see the glucose levels coming down really nicely as the patients are implementing their ketogenic dietary advice from the physician and also viewing those CGM reports at the appointments.
This is just a graph of the percentage change in our blood markers at the percentage change from the beginning of the study to the 3-month position. And we took measures of lipidemia, so all of the cholesterol markers and triglycerides. We were most interested in the change in triglycerides and obviously HbA1c. Also, our participants' compliance to the diet can be indicated by our blood markers. And as expected, everybody's cholesterol derivatives went up, and especially the HDL. This is quite important for us. We want to see the HDL going up and total cholesterol increasing, but not to severe levels, and LDL increasing, but again, not to severe levels. So that was all a good thing for all 3 of our groups. Then if we look at their triglycerides, you can see that both the coaching group and the control group decreased their triglycerides. However, the information group, who only had real-time feedback, had a slight increase overall. So this kind of tells us already that our information group is maybe less compliant, or they're slightly more diseased, as triglycerides are a severe indication of insulin resistance. Then if we look at the HbA1c, everybody reduced their HbA1c quite significantly. Then we also took fasting blood insulin. This is a once-off measure, and it doesn't really tell us too much. However, it was reduced in the control group and in the coaching group, but again, not so much in the information group. So you can see they maybe have some more insulin resistance going on. But overall, what these blood results tell us is that our coaching group was by far the most compliant. Moving on to their blood pressure measures. Again, this is a percentage change from baseline to end line. And as you can see, we expected everybody to decrease their blood pressure, and that the coaching group would do the best, that the information group would be second best, and that the control group would be last on our improvement list. Here, again, this graph represents the percentage change in blood pressure from the start of our trial to the end of the trial. And we expected that our coaching group would have the greatest reduction in blood pressure, info the second greatest reduction in blood pressure, and our control group the lowest reduction in blood pressure. But everybody reduced their blood pressure quite significantly, and all of it was, well, the most clinically significant was our coaching group. And then in terms of weight loss, again, we expected the same sort of hierarchical trend in weight loss, coaching having the greatest weight loss, info the second greatest, and control the least weight loss. However, there was no difference, no statistical difference between the three groups in terms of their BMI, their waist circumference, or their weight loss pattern. So this indicates that that weight loss is actually not responsible for the changes in HbA1c and triglycerides and our other blood markers, and that something else is actually going on there. Right, so now I hope that it's pretty clear to everybody that our participants have done really, really well. And all three groups managed to significantly lower their HbA1c. At the end line, our control group and our information group had an average HbA1c of 7.1%. And this is a clinically significant reduction. And then our coaching group did by far the best, and they had a final HbA1c on average of 6.7%. So we were very impressed with our participants and quite proud of this study. So this is this is just a pool of our remission participants. So all of the participants who were in remission at the end of our 3-month study. So they had an HbA1c of less than 6.5%, and we had 41 of them. And what you're looking at is a density plot. So more people means a brighter color, and the darker color is like no people, less people. And essentially what this is just showing you is that our participants who were in remission had essentially a lot less spiky data from their CGM. So this is the CGM data and how much time they spent in the low, target, or high percentage glucose range. So this slide shows the density plots of the number of participants who went into remission. So had an HbA1c of less than 6.5 at the end of our 3-month study. So this is in total 41 participants. And the density plot is of their CGM data. So what percentage of the time that they spent in the target range of glucose, or in the low range, or in the high range of glucose. And the higher or the brighter the spot, so the yellow indicates high density of participants, and then the dark purple means less or no people. And as you can see, basically, the CGM was providing a meaningful signal to our participants as they spent a lot less time in the low target range, most of the time in our target, which was between 3.9 to 8 millimoles of glucose, and then very little time in high. So they reduced their spikiness of their data. And this indicates to us that the CGM was actually helping them behave correctly.
We used ordinary least squares regression models of HbA1c to understand the treatment effects and different individual characteristics of patients on their end-line results. And what we found is that real-time feedback didn't have a significant advantage over retrospective intermittently viewed CGM. So that was interesting because it was contrary to our expectation. And then in pink, we're seeing that coaching decreases HbA1c by at least 0.5 on average above the other treatments. So this is a clinically significant difference and really an important result of the trial. Then in red, we're seeing that greater consumption from the red list, the avoid list, greater consumption from the red list in the month prior to the HbA1c test was associated with worse HbA1c. So the red list is effectively poison for our people with type 2 diabetes, and you can think about it this way. So 10 extra portions or 10 slices of bread would translate on average, this is just an approximation, 10 extra portions from the red list translates into a 0.2 higher HbA1c at 3 months. So here we're looking at the percentage of patients in each of the groups that came off a drug or had a drug dosage reduced. And it's clear that food was substituting for medicine in all three groups. They all had the same dietary advice, and they all followed it to different extents. So there was even more deprescribing in the info and coach groups that had the real-time CGM. And this does show some added advantage of the real-time CGM. But we can see that looking at HbA1c, coaching was necessary to sustain the adoption of the meal plan through that maintenance phase without the CGM.
Our key findings from our trial state that almost everyone who took part improved their diabetes status and their eating behavior. And we had, again, an impressive total study remission rate of 46%. However, the psychology behind the group differences is not completely understood. And we have a few theories that we're going to put forward. The first is that unsupported real-time monitoring does not necessarily hasten treatment goals. And this is exemplified in our information group. Here, they possibly had an overload of information from the real-time feedback and the CGM. It created a lot of stress and anxiety. They questioned all of their readings, and when compared to the finger prick tests, they totally spun out. Then another important fact is that they could have felt abandoned during the sustainability phase when we took away the CGM. And they didn't have that habit of finger pricking constantly because they were reliant on the real-time feedback from the CGM. Then a minimal outpatient model for remission over 3 months could look something like our control group, who did exceptionally well in our study, obviously much better than we thought they would. It's possible that the CGM, which didn't provide real-time feedback, functioned as an invisible policeman and made them really accountable for their actions when they came in and had to go through their data with the doctor at 2-week intervals. Furthermore, they were the most prepared to be without a CGM during the sustainability phase because they only had feedback from their finger pricking. Then the best model for outpatient treatment is a highly supportive one. And again, this is exemplified by our coaching group. And support was definitely a major theme throughout our study. And in fact, just simply being in our study was creating a supportive structure for our participants. And this we see based on their feedback. However, our coaching group definitely did the best. And we encourage participants to include their family members during the nutrition education doctor's visit, and so that the rest of their support group could actually understand what it really means to be a diabetic and what they have to help their family member with. So the health coaching definitely added, I think, to the sustainability phase, because now you had someone who could help you interpret your massive amount of data that you were getting from the real-time feedback in the CGM. And that's what health coaching does, right? They're there to help you integrate the information from your practitioner, in this case, both the practitioner and the device, into your life and understand it and accept it. So both the health coaching and the real-time glucose monitor were beneficial to this group. So all in all, we think that the health coaching plus CGM could be a feasible option to propose for the treatment of diabetes, perhaps on a rolling 5-year basis. So every 5 years, they get a CGM and a health coach for a 3-month period, just to help them stay on track and make sure that they're actually changing their behaviors and implementing the correct nutritional advice. And this might be a cheaper option for patients and a healthier one, as opposed to just chronically taking more and more medication to treat their diabetes.
So what's the take home? So food can be our medicine or our poison. And low-carb diets are medicine to the sugar intolerant, which is a large proportion of the world, and 67% of South Africans are pre-diabetic and potentially addicted to carbs. And in our opinion, we need a new healthcare model or a wellness model to support our doctors and address the diabetes burden. And standard of care doesn't reflect the evidence-based lifestyle treatment options, of which our model is one. And diabetes doesn't have to be a progressive chronic disease, which is the positive message of this trial. CGM can highlight unhealthy food choices and raise awareness of our lifestyle choices when it's combined with education. And it's a relatively affordable tool if it's used in a limited short-term manner, so not a chronic prescription as we previously used in other diabetes conditions.
Then some extra food for thought. This is another example where food was used for the treatment of disease. In this case, it's mental illness. This is a recent study that came out in July this year. It was a retrospective analysis of 31 adults with severe persistent mental illness, such as major depressive disorder, bipolar disorder, or schizoaffective disorder. These patients were inpatients in a psychiatric clinic in France, and they were fed 20 grams of carbohydrates per day as an adjunct to their conventional inpatient treatment care. And the duration of the intervention was about 250 days. And the results, as you can see, were quite striking. 12 out of 27 of them, or 44%, achieved clinically significant remission at the end of their trial. And 64% of all patients either reduced significantly or came off of their medication. So it's true that food can really be our medicine, maybe not just for diabetes, but for other diseases as well.
So just because we are talking about food, we can't avoid the topic of sustainability. It's important to know that actually the healthcare industry contributes a significant amount to our global greenhouse gases. And actually reducing the diabetes burden and reducing the complications and hospital admissions associated with this condition can help to alleviate the impact of the healthcare industry on the climate crisis. Thanks so much for your attention and for sharing in this discussion with us. We're really interested in your thoughts and ideas, and we're looking forward to taking this forward with the healthcare industry and anyone allied in supporting patients with type 2 diabetes.
If you would like to access any of the red and green and orange lists, they're available for free on the Nutrition Network's website, and find out about the non-profit organization Eat Better South Africa, running nutrition education programs in underprivileged communities in South Africa. And check them out.